It's wonderful. First, yes. Say,
Water quantities. Fixed one.
Your lunch, and everyone is ready to tackle this next session. Our topic: emerging technologies, targets, and therapies.
We would like to remind you that each speaker is allotted a time of 15 minutes. A bell will run when you exceed the 30 minutes to remind you that you have 2 minutes left, and about 9 minutes will be left for questions.
Without further ado, let me introduce you to our first chair for this session, Professor Carl Wilhelm Fogel. He is a retired full member of the University of Hawaii Cancer Center. As a director of the UH Cancer Center, Dr. Fogel renewed its NCI designation twice. He was also responsible for actively expanding the UH Cancer Center's area of services from Hawaii to include the US Associated Pacific Territories, at the core of which was the initiation of a long-term partnership with the University of Guam, supported by sequential U56 and U54 grants from the NCI and continuing today.
And I introduce our second chair, Dr. Vandana Bakri-Baktua from G2 Hospital, Port Louis, Mauritius. She obtained her MBBS degree from Lady Hardinge Medical College, Delhi University, India. She also holds a diploma in gynecology and obstetrics, DGO, BAMC, at Safdarjung Hospital, Delhi University, diploma in ultrasonography, Delhi University, MRCOG, London, UK, and MD obstetric and gynecology from UTM, and a diploma in postgraduate assessing from UTM. Please give a round of applause for Dr. Vandana Bakri-Baktua. Thank you. I would like to call on stage our first speaker, who will speak on detection of ischemic heart diseases by an AI ECG, Professor Tilak Kumar Ganesh. Dr. Tilak Kumar Ganesh is a cardiac surgeon and currently Director of Cardiac Services at the Cardiac Center, Pamplemousse. He is an honorary professor in medicine, University of Mauritius, Fellow of American College of Cardiology, membre de l'Académie nationale de chirurgie in Paris, and Fellow of Imperial College. He is also actively involved in the University of Mauritius, where a member of the Council and Senate. Please give a hand of applause for Professor Tilak Kumar Ganesh. Thank you.
So, good afternoon, everyone. Thank you for being present. Thank you, organizing committee, to give me the opportunity to call AI ECG. Actually, it's not the AI ECG, it's the AI PCG, and I'll show you why. in a few minutes. So, why I became interested with this subject? It's because of the problem in motion. You know, these are some figures in motion, fit in motion every day. You have to do an far 90, 50% of population is either diabetic or pre-diabetic. 90% of diabetic patients, they are symptom-free prior to heart attack. And look at the last sentence, more than 75% of patients discover that they have got ischemic heart disease when they do their first heart or when they do their first ACS. So this is really a very alarming situation. And we all know that all risk factors are in the right emotions. Obesity, diabetes, cholesterol, hypertension, everything is in the right. And we are getting a lot of ischemic heart disease, a lot of infarct. At the cardiac center, we do primary PCI, we do cardiac surgery, and it's really terrible when we see young patients with completely damaged heart. So why the disease can't be detected at an earlier stage? Why do we have to wait for an infarct to detect the disease? This is what troubled me for some time. What is missing in our methodology? And we need a reliable, non-invasive, user-friendly examination tool to detect CHP before a heart attack, before the muscle is damaged, and that can be easily available in our primary care setup. You know this, very often patients go to the hospital with chest pain, the doctor does an ECG, and then he tells him, ECG normal, you can go home. A few hours later, this patient suffer from massive heart attack. We all say the doctor is not good. It's not that the doctor is not good. It's that the ECG is old. It's a 100 years old technique, and it has made its proof, but now people change. The doctor, he sees what he sees in the ECG, and the ECG has got a sensitivity of only 40%. If we do a stress echocardiography, a stress ECG, we will go to 50%. All these are insufficient. ECG 40%, it means that in 60% of the cases, the doctor is saying everything is right. Sensitivity is true positive, only in 40%. And complex congenital non-invasive diagnostic tools like CT angio, like heart scan, they are not easily available. Stress echocardiography, not easily available and not done in Mauritius. The coronary angiography is the golden standard, but we will not do it in a primary setup. We will not do it in the medical. We need this artificial intelligence, the cardiography. The cardiography, so I'm sorry, I went. This is from the Ministry of Health. They have devised a paper where when you go to the medical clinic, they will see your risk factors, and if you get a score more than 12, they will do an ECG with you. But today they are doing the cardiography. In many primary setups, in medical clinics, in dispensaries, in mobile clinics, we are doing the cardiography. The cardiography is going to detect the problem here at the level of tissue, whereas the conventional ECG is going to detect the problem at the level of the muscle. So the cardiography is summarized. The cardiography, 5-lead, 3-dimensional ECG AI. There are only 5 leads instead of 10 leads in the normal ECG. 3-dimensional representation of the heart, of the electrical activity of the heart, is the electrocardiogram and using AI. This was the first publication of the cardiography. It was in 2000. In 2020, in the Journal of Electrophysiology, the sensitivity 97%, specificity 76%, and small variation in the female gender. But a sensitivity of more than 90% compared to ECG, which is around 40%, and stress ECG, which is about 50%. When we see the other tests available, stress ECG, then the stress echography, then when we see the heart scan or the angiography, we can see these of figures I've already told you. So 50% for the stress ECG, about 85% for the stress echocardiography, 90% for the CT heart scan, and 100% of course for the angiography. This is a busy slide. I will not go into the details. It shows all the advantages of the different techniques available. we will not get them in the primary setup. We will not get a troponin in the primary setup. We will not get CT scan and so on and the primary setup. Now I'm going to explain to you what is cardiography. First, let us see the ECG. The ECG has got 10 leads, and what we do, the heart is a sphere. What is the ECG? You will recall during our studies, we learned that we take the heart, we will crush it on the table, and we will make it become flat, and we will register the electric activities in two axes, X and Y. We are going to plot the potential difference between two regions of the heart in an X and Y axis. We will transform a spherical heart to a b-dimensional ECG. You will agree with me that we will lose electrical activities which go posteriorly at the back. So this is where the vectorcardiogram comes. The vectorcardiogram is going to make a three-dimensional representation of the electric activity of the heart by putting an electrode at the back. We learned this when we were students about vectorcardiography. And the vectorcardiography, we learned it, but it was so complicated that we also learned to forget about it. And at that time, we didn't use it. When we do a vectorcardiography, we get loops. The P wave, the QoS wave, and the T wave becomes P loop, QoS loop, and T loop. It is a three-dimensional representation of the heart, but very complicated to be analyzed and to take advantage of all the results that we get. I will just tell you that the American Heart Association today recommends to put electrodes B1 to B6, but also B7, B8, B9 at the back to get the to get the posterior electrical activity of the heart. So the vectorcardiography is a three-dimensional representation of the electrical activity of the heart. The P loop represents the depolarization of the atrium. The QoS loop represents the depolarization of the ventricle, and the T loop represents the repolarization of the ventricle. So P wave, QoS wave, T wave becomes P loop, QoS loop, and T loop. Very good. It also allows us to calculate, other parameters like the maximum vector analysis, the angle QRST, and some details of that. Just follow. This is I told you it was difficult to use. That's where the artificial intelligence comes, and this artificial intelligence it uses an algorithm. The cloud is in Frankfurt, in Germany, and you will see how we do it practically. But the basic thing is that the vectorcardiogram is analyzed by an algorithm. Something that was difficult 20, 30 years back is now becoming easy, and we can take advantage of this vectorcardiogram. Just follow this. Just follow this. I hope it works. Yes. So when the P wave comes, so you get the P loop, then you get the QRS loop, and then you get the T loop. Okay? So this is what is done in the vectorcardiography. So the cardiography performs a three-dimensional scanning of the heart and its electrical activities, which are a process which are analyzed by AI algorithm. And this AI algorithm gets improved every day as we feed it, and as we feed it. And this is the system. You have got at the patient, a cardiograph. Then you've got a web. You've got a laptop with the cardio web system there. It is sent to the cardio cloud by internet, analyze, come back again. This takes 4 minutes. This takes 4 minutes to go and come back again. And then the analysis takes 4 minutes. In all, it takes 12 minutes to have a result with a sensitivity sensitivity of 90%. And this is how you place electrodes. You've got 4 electrodes in front, 1 electrode at the back, and this is the laptop, and the results come back again, and we are going to interpret the results. What do we get in the results? In the results, we get the vector-cardiogram result. I'm going to go into the details. We're going to get an absolute cardiogram. You've got a rhythm analysis. You've got a normal district. You've got a 12D district, and you've got an interpretation of the results. We are going quickly to go in there. So one of the first components of the VCG result is the CSG index. The CSG index is users' article resistance, and the cutoff value is 0.27. Something which is inferior to 0.27 means that there is no reduction in blood flow in the coronary arteries. Something which is superior than 0.27 means that there is a reduction in the blood flow. Reduction, it doesn't mean stenosis. It can be stenosis, it can be inflammation. For example, during the COVID period, there were many young patients with CSG index more than 0.27, but it was more inflammation of the coronary arteries. So something that is less than 0.27, the arteries are here, there is no blood reduction. Something where the result is more than 0.27, the result is positive. Then we will see the vectors Q, R, S, and T. These vectors must be between minus 30 degrees to 90 degrees. And they are measured in the frontal plane. And when the QRS vector is not in this green area, it means that there is a problem with the depolarization. When the T wave is not, T loop is not in this area, it means that there is a problem with the repolarization. So we are going to see in which directions the QRS vector or the T vector goes, and normally it should lie between minus 30 and 90. Then we measure this angle. This angle is well known for well-known people. We didn't used to measure it before, but we know that an angle which is superior than 100 is a strong and independent predictor of cardiac failure. This is supervision, normally the T loop, and should be within the QRS loop. And we must get a supervision of more than 50%. If we get a supervision of less than 50%, for example, the T loop is in this direction, it means that there is a big issue with the perfusion in the coronary artery. This is a very important element. Each dot here and here, each dot here represents the one QRS vector. Each dot here represents a one T vector. And scattering means that the dots are not together. Normally, in a normal patient, the dots should be together like this. But when you see here, one dot is here, one series of dots here, one series of dots here, it is a scattering of the QRS. And in principle, you get this when there is scar tissue on the heart. This is scattering of the T vectors, and this one means that there is a problem with the perfusion. All the three vectors are not together. This one is reversible, this one is irreversible. There are a lot of information. I'm sorry, I will not be able to go. This is the 15 minutes the bell will ring. The T magnitude, it must be more than 0.4. If the T magnitude is less than 0.4, it means there is a problem. Scattering T and T magnitude, if they are present, it means there is a problem with the particle. And they are very good parameters to follow improvement. When there is improvement, the T magnitude will come near to 0.4 and the scattering T will disappear. Absolute cardiogram, I will not go into this. It is not for ischemic. There is a lot of information on the rhythm analysis, and we will not have time to do this. But I will come and I will, yeah, I'm sorry. I want to present two cases of this. So here, for example, the P index is positive. It has taken into consideration the CSV index. It has taken into consideration the strategy and the T magnitude. So each time when it is positive, it will tell you which parameters it's taken into account. And these parameters, we have got weighing values, right? The CSG has got a strong weighing value. This is the case, I just present this case, it's young 40 years old with, typical chest pain, ECG was positive, with the ST negative, and the stress test was done, the echography was done, and let us see what the cardiography shows. The cardiography shows a CSV index which is positive. It shows a T magnitude which is less than 0.4. It shows an angle which is more than 100, and it shows the T vector not in the right direction. This factoring is good. You can see this factoring is good, and this is a positive cardiography. We did the angiography, and the angiography showed a tight lesion of the LVT, which was dilated. I will not show this one. I will not show this one. I will show this one. So this one is a male, 47 years old, a 63 years old story. And you see atypical chest pain, no diabetes, no smoking, no family history. BMI was good, good as function, atypical chest pain. We did the cardiography, which was positive for ischemic heart disease. You see, look here, you've got a P-index, formerly we called it P-index, now we call it CSV index, positive. The strategy is positive, and then, we did the angiography, and the angiography showed 100% occluded, T1 occluded. I am going to stop. Yeah, I'm going to stop. Thank you very much. I am ready to answer your questions. No, you're right. Tell me, any questions from the audience?
Tell me, it takes 12 minutes to get the results.
12 minutes.
Let's say in an acute setup.
No,
No.
yeah, no, we don't use it in an acute setup. For me, it's not to be used in an acute setup. It's to be used more in the preventive, in the primary or secondary setup. Not in an ICU, no.
Thank you very much, Dr. Ganesh, for the nice presentation. I just wanted to ask you whether you have any experience of using this application in pregnancy, in pregnant ladies. Because we do get with the changing demographic profile, we are getting ischemic heart disease in pregnancy as well.
What we are doing in Mauritius and elsewhere, when we have got long surgery, we will do this, the anesthesia strategy. Instead of doing a routine ECG, we do the cardiography and it guides the anesthesia how to manage the situation. Long general anesthesia surgery. They have used it a lot in COVID patients. They have used it in sarcoidosis, patients, amyloid patients, and these stuff. I don't know of any specific use in pregnant.
Because of time, we have to stop the discussion, and I'm sorry, and we will have the introduction of the next speaker.
Thank you very much.
Thank you, Dr. Ganesh, for this nice presentation. Our next speaker will be elaborating on cardiac disease modeling using stem cell-derived cardiomyocytes. Professor Krishan Ramachandra. Please give a round of applause. Dr. Krishan Ramachandra is a junior principal investigator at the National Heart Research Institute, Singapore, and assistant professor in the Sing Health Duke-NUS Cardiovascular Sciences Academic Clinical Program. His research focus is on identifying novel therapeutic targets for heart failure by using patient stem cells to model monogenic and multifactorial cardiac diseases. He has established stem cell model of arrhythmia, cardiomyopathies, and heart failure, and these models have facilitated the discovery of new and personalized therapies, some of which are undergoing clinical evaluation. Please give a round of applause for Dr. Anna.
Thank you for that kind introduction. Hello, everyone. So before I begin, first I'd like to thank the organizing committee for the kind invite to present here today. It's been an absolute pleasure. And what I'd like to do is sort of shift gears in my talk. And over the past 2 days, you have been hearing a lot of nice research revolving animal models and how they can be used to identify new therapeutic targets. However, what I'd like to do is talk about how we can use patient-derived stem cell models to do the same thing. So I'm sure I don't need to go too much in detail what heart failure is. It's the leading cause of death and disability worldwide, and it's also the leading cause of hospitalization. Now, of course, heart failure has multiple etiologies. This can be familial, such as hypertrophic cardiomyopathy, dilated cardiomyopathy, or it can be also acquired, such as diabetic cardiomyopathy or AMI for that matter. Now, a small point about Singapore and Southeast Asia, and it's not something we'd like to be proud upon, but heart failure actually appears to come on much earlier, at least 10 years earlier in this region. And when it does come about, it's actually much more aggressive as well. So, of course, needless to say, there's an urgent and unmet need to identify new therapeutic targets and treatments for preventing heart failure. Now, in order to find new therapeutic targets, the approach which we use is using patient-specific induced pluripotent stem cells. So I'll just run through this very quickly. So in 2006, the Japanese scientist Shinya Yamanaka, he showed that you could take a somatic cell, which is terminally differentiated, and if you treat it with a combination of transcription factors, you could basically reset the clock on this cell, and it becomes a pluripotent or embryonic-like cell. And then you can sort of differentiate this into any cell type you like. So of course, we being a cardiac lab, what we do is we recruit patients with various types of heart failure, and the somatic cell which we reprogram is patient blood. So you just need 5 ml of blood. You isolate the peripheral blood mononuclear cells, reprogram it to stem cells, and then we differentiate them into cardiomyocytes. Now, of course, these cardiomyocytes being derived from the patient themselves have several therapeutic applications. For example, they can be used for personalized treatments, novel target discovery, risk stratification, and cardiotoxicity. So I won't go into too much details on all these applications, but of course, I'll be happy to take any questions at the end of the talk. So in summary, these iPSC models are powerful tools for gaining valuable insight into human cardiac physiology and disease. However, I must highlight there's one caveat to using these models. Basically, these models depend on the patient having a genetic or epigenetic predisposition towards a cardiac condition, because the whole ability to model that disease depends on some genetic factors being carried into these models, and therefore these models exhibiting that disease. So based on this, it's not surprising that we and other researchers have been able to model model cardiac diseases with clear genetic links, such as hypertrophic cardiomyopathy, long QT syndrome, CPVT, and so on. And so today's talk is going to be on two models. One is a disease model which has a very clear genetic link, and we'll talk about how we can target the mitochondria as a potential target for this disease. And the other is on heart failure with preserved ejection fraction, which is not known to have a genetic link. And we'll talk about MPO as a potential target. Yeah. So what is hypertrophic cardiomyopathy? So we know it's a familial condition. There's a rather high prevalence of 1:500, although some studies actually report that it can be as high as 1:250. And it's the common cause of sudden cardiac death in young individuals and athletes. The disease primarily manifests as a thickening of the ventricular wall, and this can be seen very obviously in this HOCM heart, where we can see the ventricular wall is extremely thick compared to a healthy heart. And it's also accompanied by other manifestations such as cardiomyocyte hypertrophy, disarrayed myofibers, and interstitial fibrosis. Now, what all these pathological features result is in a very stiff heart, and what you end up with is impaired left ventricular relaxation and diastolic dysfunction. So, with regards to the pathophysiology, of course, mutations primarily in sarcomeric proteins, which are proteins which cause the myocyte to contract, have been identified as the driver of this disease. And work done over at least 30-40 years have shown that that initial mutation in the sarcomere proteins can have these knock-on effects of secondary, tertiary, and tertiary defects, which eventually lead to the clinical phenotype. But what I'd like to draw your attention to is mitochondrial dysfunction, which has been always considered some sort of something secondary and not a key driver of the disease. However, we hypothesize that it's actually not a downstream effect, but might be one of the early drivers of HOCM. And the rationale for this hypothesis is based on some of the clinical findings where researchers have found that myocardial energetics are reduced in asymptomatic HOCM patients. And what is more convincing is that they've also found energetic abnormalities in patients who are genotype positive, but have yet to develop hypertrophy as well. So it does seem that this might not be a late consequence of mechanical dysfunction, but it could be an early manifestation. And so our study was to, our study was to determine how mitochondrial dysfunction occurs in HOCM and to identify ways to protect the mitochondria. And so to answer this question, we recruited patients carrying mutations in two sarcomeric genes, one in the myosin binding protein C and the other in the myosin heavy chain 7. And the reason we recruited these patients is because mutations in those two genes account for more than 50% of familial cases. And so we went through the process of making the stem cells, differentiating them into cardiomyocytes, and okay, never mind. Oh yeah, okay, so there we go. Yeah, so we can clearly see that these are the control cardiomyocytes. They have a very rhythmic contraction and relaxation cycle, which is very evident. However, what we see in this HOCM cardiomyocyte, I think it's very obvious. What you notice is that after the contraction, the cardiomyocytes actually get sort of locked in a hypercontractility state, and the relaxation is impaired as a result of that. So after making these cardiomyocytes, we wanted to phenotype them to make sure that they sort of match the clinical features which we see. And so what do we look for? So we obviously look for cellular hypertrophy, and we can clearly see that the patient cardiomyocytes are much larger than the control. If you were to test them at fast electrical frequencies, basically like a stress test, we see that these cardiomyocytes go into arrhythmias, which are indicated by the red arrowhead. But most importantly is that we see that they have impairment in their calcium handling as well as their contractility. So what these traces show is that the calcium release and the contraction are more or less preserved, but we can clearly see that the relaxation is much more prolonged in these cardiomyocytes as well. So at this stage, we were sort of happy that we have made a suitable model that matches the clinical phenotype. So the question we wanted to ask is energetics impaired? Because that's our initial research question. So to measure energetics, we did a seahorse. So I won't go into too much detail. So basically what this does is it measures oxygen consumption rate of the cells. And higher values on the graph means that the mitochondria are performing better. Lower values means they are not as performing as we would expect to. And we can clearly see that in the control cardiomyocytes, the OCR is very high. The Hokan cardiomyocytes have a much more reduced mitochondrial consumption rate. Now, we also wanted to look at metabolism because, of course, metabolism and mitochondria go hand in hand. And we know that the healthy heart, we know that the healthy heart is a sort of an omnivore. It can consume many fuel products, and it relies primarily on fatty acids. But when it is stressed, it can consume glucose, lactate, and other metabolites. Now, this flexibility is actually lost in failing hearts, where the heart tends to switch to other substances. And so what we wanted to do was we did a metabolomics profile on these control and disease cardiomyocytes. And if we look at the metabolic profile, for example, C16, which is palmitate, and C18-1, which is oleate, we see that the controls, which are in blue, are consuming that fuel product, but that is reduced in the Hokan cardiomyocyte. Now, interestingly, we see that if you look at the short chains, which are derivatives of branch chain amino acids, we see that there is actually a switch in the profile. So these cardiomyocytes not only have a mitochondrial dysfunction, but they also have a change in substrate preference as well. So we wanted to know why this happens, and we speculated that it could be because of changes in mitochondrial dynamics. So now mitochondrial dynamics is basically a process where the mitochondria can actually fuse together, which we call fission, or it can break, and which we call fragmentation. And in our previous study, what we showed is that fatty acid metabolism is actually associated with filamentous mitochondria. So now, given that these Hokan cardiomyocytes have a reduced fatty acid consumption, we hypothesized that there might be more fragmentation. And so we did some immunostaining, and what we can see is the mitochondria is stained in green, and we can see that in this control cardiomyocytes, the mitochondria are very filamentous, spanning the sarcomeres. And what we can also see is that this is fragmented in the Hokan cardiomyocytes. And later on, what we found is that there is actually a sort of, so now we wanted to know why this is happening. And what we found is that when we looked at the proteins that are responsible for the fusion and fission mechanisms, we found that fission is actually hyperactivated in these cardiomyocytes as well. I won't go too much into the details. So basically what we wanted to do was we wanted to see if we were to inhibit mitochondrial fission, can we restore the energetics and can we improve contractility? So we used a chemical inhibitor known as MTV1, which blocks one of the fission proteins. And what we found was that those fragmented networks actually start to get elongated. And that's associated with a better respiration rate. And what we also see is that there's better contraction time and relaxation time as well. So moving on to the next model, which is heart failure with preserved ejection fraction, we know that this accounts for 50% of heart failure cases and is characterized by diastolic dysfunction with preserved systolic function. And it's typically considered a comorbidity-driven disease. And it's usually associated with elderly people. But I think our idea of HFpEF is actually changing. And a lot of cohort studies are now showing that apart from your classical aged individuals who have HFpEF, you also have these individuals with a younger phenotype and also with a metabolic syndrome as well. And so if you look in Asia as well, if you look at 11 Asian heart failure registries, so this is not segregating HFpEF and HFrEF, we see that the HFpEFs cluster into three main groups, which are the elderly, which is expected, and we have this sort of metabolic HFpEF, a lean diabetic, that is an individual who has diabetes but not obese, who has HFpEF and the typical metabolic syndrome as well. So we hypothesize that can we model this using iPSCs, because after all, this disease seems to be appearing in certain young individuals as well. So there could be maybe a genetic or epigenetic link. So we, recruited patients with HFpEF, and we started phenotyping them. We made the iPSCs. And what we found is that they do have hypertrophy, and this work is done by our fourth-year PhD student, Ping. And what we also found is that the contractility is well preserved, but the relaxation time is impaired as well. So now that we have this model of HbF, we wanted to pursue this target known as myeloperoxidase, which is a heme peroxidase expressed mainly by neutrophils and endothelial cells. And interestingly, high levels of MPO in the circulation has been associated with worse cardiovascular disease outcomes. And also, high levels of MPO in the circulation is associated with worse outcomes in HbF. But this is all MPO in the circulation. And what we wanted to know was, what does cardiomyocyte MPO do? Because previously what we showed that at least in HOCM cardiomyocytes, you have an upregulation of MPO, which actually contributes to the relaxation impairment. So now that we have these iPSC cardiomyocytes showing the HbF phenotype, we looked whether there is an increase in MPO expression, and which there is. And we confirmed it by immunostaining, where you can see the controls have a basal level, which is elevated in the HbF cardiomyocytes. Now, we wanted to complement this model using a mouse HbF model as well to see whether what we are seeing here sort of matches a sort of physiologically relevant model. And the model we chose was this model which was published by the Hill Group, and it sort of becomes a bona fide HbF model where you induce hypertensive stress to L-name to cause microvascular dysfunction, and you give high-fat diet to cause a metabolic stress. And what happens is that this mouse, over a period of 10 weeks, seems to develop preserved EF, diastolic dysfunction, concentric hypertrophy, lung congestion, and reduced exercise capacity. And interestingly, in these mice, what we see is that there is an elevation of MPO in these hearts as well. Now, we also need to take into consideration that a whole heart has multiple cell types. So this MPO signal can be coming from various cells, including cardiomyocytes. And indeed, that's what we saw as well. If you look at the cardiomyocytes, we can see there is a MPO staining, but we can also see an MPO staining in the vasculature as well, which is not surprising. And so the question was, if we were to knock down MPO, what would happen to these mice? And so we took a genetic strain where MPO has been knocked down. And as you can see, the mice develop weight because they are on high-fat diet. Their EX is preserved. But what's very interesting is that these MPO knockout mice, so we can see the normal wild-type strains, they have diastolic dysfunction. We see that there is a drastic reduction in the E over E prime in these mice as well, suggesting that they are probably protected against this. And so to summarize and conclude, what we have shown is that patient iPSC cardiomyocytes can model these two diseases. Targeting mitochondrial fission can improve the function of the mitochondria, and in doing so, improves the contractility. MPO is upregulated in HbF cardiomyocytes, in hearts from HbF mice, and it can prevent diastolic dysfunction if it's knocked down. And I think the interesting finding is that the ability to model HbF in iPSCs actually suggests that there might be some sort of underlying genetic or epigenetic link to this disease as well. And so with that, I'd like to thank the following individuals and teammates, of course, Derek Hausenloy and his team, Winston, as well as Nicole for helping with the ECHOs as our funding agencies. And of course, last but not least, I'd like to thank the people of Mauritius for making us feel welcome, and it's been truly remarkable trip as well. Thank you. I'm happy to take questions.
Thank you, very nice talk.
Thank you.
Usually, all these IPS models have a problem of the immature type of this IPS organoid. So, what is the maturation state and what markers you measure?
Yeah. So that's a very good question, and that's something which we always get criticized on. What's the maturation state of these myocytes? But I think we in the field have moved forward. So one marker, of course, one functional marker which we do look at is we pace our cardiomyocytes. So if we pace the cardiomyocytes and they respond to the pace, so that means they have a very functional, they have an active contraction, contraction coupling system. So that's one of the things. The other marker which we look at is troponin T isoforms, where we have found that the immature myocyte has a higher band on the Western blot, whereas the more mature ones have a sort of a lower band on that. So we have sort of compared this with some of the old papers published in Circ research, I forget, where they have also done comparisons on human myocardium, where they sort of show this transition in the troponins as well. So this is one of the markers which we use. Of course, some people do tend to use fatty acid metabolism and things like that, because of course the adult myocyte metabolizes fats. But in the case of disease, that's actually a poor marker, because you have this sort of change in substrates, and so you can't really use fatty acid elevation as a good indication of maturation.
Great talk. Yeah. So just wanted to ask you about the test model. So what is the I saw that you have calculated cardiomyocytes and you're trying to see hypertrophy in that. Yeah. But not necessarily cardiomyocytes is the primary reason for HFpEF, right? This could be inflammation leading to fibrosis, stopping this.
Yeah, exactly. So the thing with HFpEF, it's sort of considered a systemic disease, not really purely cardiomyocytes. It's not like something like cancer. So right now we're trying to take one step at a time. So we're looking at the cardiac manifestation of HFpEF, the cardiomyocyte problem. And of course, we have plans to differentiate these patients into endothelial cells and sort of try to create a co-culture and eventually an organoid to see whether we can sort of mimic a more physiological in vitro model in this aspect.
Okay, thank you very much. Okay. The chairs would like to ask the remaining speakers to make sure to stay in their allotted time of 15 minutes. It is much nicer that we have to interrupt.
Okay, our third speaker for this session will be elaborating on hyposignaling pathway in modulating immune response and inflammation-driven tissue and repair by Professor Mahavendra Singh. Professor Mahavendra Singh is an assistant professor in the signature research program in cardiovascular and metabolic disorders at the Duke-NUS Medical School. Dr. Singh also holds an appointment in the National Heart Research Institute, Singapore, National Heart Centre, Singapore. Dr. Singh received his MSc in biotechnology from Madhuraj Kamarad University, India. Dr. Singh also obtained his PhD in developmental biology from Hannover Medical School, Germany, and postdoctoral training in Columbia University and the University of Pennsylvania, USA, specializing in cardiovascular development. Please give a round of applause for Professor Mahavendra Singh. Thank you.
Thanks for the kind introduction. And I would like to start by just thanking all the organizers, local as well as our international organizers, for bringing us here in Mauritius, so we can share some of the work we are doing at Duke-NUS in Singapore, as well as we can interact with our future clinicians. So what I'm going to do today is talk about this pathway, known as the hyposignaling pathway, which mediates the inflammation and fibrosis. So initially, I was thinking to share some data on pulmonary fibrosis. We have some very interesting data related to MMP. That's why I talked to our Hungarian friend in the morning session. But then I decided to stay with the theme of the symposium. And, I'm going to talk about role of hyposignaling in fibrosis related to cardiovascular research. So, as you all know, that cardiovascular diseases are the leading cause of mortality worldwide. And if you look at among the type of different cardiovascular diseases, you can find the ischemic heart disease the leading cause, followed by dilated cardiomyopathy and hypertrophic cardiomyopathy. As we all know, that cardiovascular diseases are highly associated with age. So these numbers are going to be significantly increasing over the next decades. Due to aging population. So coming back to the ischemic heart disease, as you all know, that ischemic heart disease is characterized by the blockage of the coronary arteries, leading to ischemic condition here, and that leads to loss of millions of cardiomyocytes. And slowly these cardiomyocytes are then replaced by fibrotic tissue derived mostly from epicardium of the heart. And those fibrotic scar then leads to the problem with the functioning of the heart, leading eventually to the cardiac heart failure. So our goal is to understand how this process occurs, how we can improve the cardiac repair or regeneration process. So there are two cell types that we are interested in looking into the role of HIPA pathway, and those are immune cells as well as fibroblasts. So Let me just briefly talk about the ischemic injury. So as we all know, the repair process after ischemic injury is highly regulated. This can be divided into three phases. The first phase is inflammatory phase, where the majority of the immune cells, they invade the ischemic area. Neutrophils and macrophages is shown here. And then the second phase is the proliferative phase, where the vascular, smooth vascular cells, endothelial cells, and fibroblasts, they expand and try to replace the lost cardiomyocytes. And then the third phase is the remodeling, where the scar maturation occurs, followed by the remodeling, and then this is called the electro functioning of the heart, defect in the functioning of the heart. So if you look at the immune response, especially the macrophages, and there are two phases. The phase one is basically M1 macrophages or inflammatory macrophages, and they are pro-inflammatory in nature. They regulate phagocytosis to remove the damaged tissue. And in the phase two, they are reparative macrophages or the M2 macrophages, and they are pro-fibrotic in nature and anti-inflammatory in nature, and they regulate angiogenesis and tissue remodeling. And as we all know, that the macrophage polarization, so M1 or M2 or pro-inflammatory versus anti-inflammatory or pro-fibrotic, the balance between these two different phenotypes or different polarization state that decide the amount of inflammation and fibrosis occurs in the damaged tissue. The signals derived from these M1 or M2 macrophages, they also affect the fibrosis by signaling to the fibroblasts. And these fibroblasts, like here you can see, if there are TGF beta signals, the fibroblasts can differentiate into myofibroblasts, and these myofibroblasts are the primary source of the extracellular matrix in the damaged tissue. So just brief introduction about the pathway we are studying, hypersignaling pathway. So this is the kinase cascade. So upstream kinases followed by downstream effector molecule GAP and Cas. So once there is the external stimuli, including the ischemic injury, the pathway is activated, and starting with the MST1 and 2 interaction with Salvador. That interaction leads to the phosphorylation of LAS1 and 2. And LAS1 and 2 then the phosphorylate downstream effector molecule GAP and Cas. So when GAP and Cas, they are phosphorylated, they can either get degraded or they can stay in the cytoplasm. But when they are not phosphorylated, they can translocate to the nucleus. They can interact with the different kind of transcription factors, including the key transcription factors, and then regulate the target gene expression. So when the pathway is active, the YAP-Cas is phosphorylated and stay out of the nucleus. So YAP-Cas mediated gene expression is suppressed. So our goal was to understand, my lab has been working on this pathway for a number of years, and we have shown, we have established role of this pathway in the embryonic epicardium, and we have shown how embryonic epicardium contributes to the coronary vasculature during the fetal development, as well as we have shown the pathway is activated in adult epicardium after ischemic injury, and it regulates the inflammatory, the homing of the inflammatory cells in the injured tissue. But when we started looking at this pathway, there was not much known about whether YAP-Cas has or his pathway has any role in immune cells. So we tried to do a quick experiment. We decided to take just normal bone marrow derived macrophages from wild type animals, give them M1 stimuli or M2 stimuli, and then try to see what happens to YAP and Cas. So what you can see here, the expression of YAP and Cas is significantly upregulated in BMDMs after LPS treatment. And if you do siRNA mediated knockdown, you can see IL-6 expression, which is the inflammatory marker, and one marker, it goes down. And not only IL-6, but majority of the inflammatory genes were significantly down-regulated when you use YAP or YAP-Cas both. So this quick in vitro experiment gave us confidence that the YAP-Cas has an essential function in macrophages regulating immune response. So then we decided to delete YAP and Cas in vivo, and we decided to delete in macrophages using lyso-M3. So we generated these double knockouts where you have YAP-Cas deleted only in the macrophages. Everywhere else, YAP-Cas is intact. And we took the bone marrow derived macrophages from the control and knockout mice, and we stimulated with M1 stimuli and then performed RNA-seq experiment. And what we found, the majority of the inflammatory response gene, especially the M1 marker gene, they were all significantly downregulated. So this exactly mimics what we saw in our initial in vitro study. So the second step was to looking more closely on these genes, how the YAPTAs are regulated. So as I mentioned, YAPTAs are transcriptional coactivators. So we look in the IL, we choose IL-6 as the target gene, and we look at the promoter of these, and we found that a bunch of key binding sites. So as I mentioned, the YAPTAs needs to interact with the transcription factor to regulate target gene expression. So these key sites, then we tested in a luciferase system where we clone this promoter with a luciferase reporter, and you can see when we put the reporter with YAP or TAS, there is a significant increase in the luciferase activity, suggesting that YAP does regulate this promoter. And if you mutate these sites, then this activation is abolished. We also tried to do chip assay, so in the chromatin immunoprecipitation to show the YAP has directly bind to these promoters in the dish. And similar results we also observed with the vertiposing factors. So overall, what we concluded with this that you need YAP and CAS for the expression of pro-inflammatory genes after ischemic injury. We also looked into M2. So we also isolated these BMDMs and treated with M2 stimuli. And what we found, in contrast to what we see in M1, now we see majority of the M2 genes, they are significantly upregulated in the mutant. And similarly, like if you look at the protein level, we had the same thing. So both at the protein level, RNA level, we see upregulation of M2 marker gene in the YAPTAZ knockout. And then we decided to look what happens to YAP and CAS expression after M2 stimuli, and we see YAP CAS expression in both cases goes up, suggesting that when there is a M1 or M2 stimuli, YAP CAS goes up, but in M1 case, it's acting as an activator for IL-6, but in M2 is acting as a repressor, and repressing the M2 expression. So we took one of the candidate, arginase 1, and again made a luciferase reporter, and you can see in presence of YAP by CAS, the reporter activity is suppressed. And this is just to show again that YAP CAS can directly bind to arginase 1 promoter and suppress the expression. So to understand how YAP CAS are behaving in a completely two different manner in two different cell types, but it's the same ischemic injury setup, we decided to look at what kind of repressive complex they can interact with. And what we found that YAP CAS interact with HDAC3 and co-repressive complex to inhibit anticoagulation. So as you all know that there are two different chromatin states, euchromatin and heterochromatin. So what happened in this case, like you have the histone acetyltransferase, what they do is they acetylate the histone, leading to relaxation of the chromatin. And in this stage, then the transcription factors, they can easily bind to the promoter. Promoters are accessible and maintain the transcriptional activation state. What HDACs they do just completely opposite of what histone acetyltransferase they do. They remove the acetylation from the histones, and then leads to the compaction of the chromatin and leading to the transcriptional repression. And what has been shown that HDAC3 interacts with anchor-repressor complex and remove the acetylated histone, leading to like suppression of the target gene. So we performed co-immunoprecipitation assay in two different cell types. One is raw cells and bone marrow-derived macrophages. So you can see in both cases when you do the pull down with the flag meets HDAC3, you can detect YAP and the other way around. And in both cases, we can see the YAP is nicely able to pull down HDAC3 as well as the encore, suggesting that they physically interact with each other. Again, we tested whether the repressor complex and interaction with YAP can also affect the arginase 1 luciferase reporter. So you can see in the presence of YAP, there is a repression, and HDAC alone can also repress, but when they put them together, it will be a major repression. And so they definitely work together and to repress this promoter. And same results were observed with the HDAC3. In addition to that, what we did, we also used a YAP mutant form, which is the constitutively active form. So it's always going to be the nucleus. And in that case, the suppression of arginase 1 luciferase construct is way more than the control, suggesting that YAP does interact with JAK3 and protein complex on this promoter. So to further prove this point, what we did, like we use STAC inhibitor. And so what you are trying to do is like you plot the STAC3 activity or STAC activity, and then you see whether the repressive activity is removed. And that's what we see here. So there is an increase of this reporter activity suggesting loss of repression. But the problem here was that the pan-HTAC inhibitors, they not only remove the deacetylase activity, but they also degrade the HTACs. So there is a loss of the protein. So using this system, we are not able to see whether HTAC3 is structural function or the enzymatic function, which one is responsible for this repression of RT1 promoter. So we decided to use a more selective inhibitor, SDAC3 inhibitor, and this inhibitor has shown that SDAC3 only it blocks the deacetylase activity, but does not have any effect on the protein level of SDAC3. And in this case, you can see it does not have any effect, suggesting that the structural function of SDAC3 is important for this arginase-1 repression or M2 gene repression. We also took a step further and we generated a mutant form of SDAC3 which does not have any deacetylase activity. And again, you can see there is no change when you use this mutant form compared to the wild-type form, suggesting that deacetylase activity of SDAC3 is not required for M2 gene repression. So what happened, like now, when you have this state where you have a less M1 gene and there is an increase in M2 gene expression, and how this affects the cardiac function after ischemic injury? So we used the knockout and we created an MI model, and you can see in the post-MI model, the ejection fraction is much more protected in the knockout. And so overall, if you look at all the parameters, this suggests that there is an improved recovery of cardiac function in YAP-TAZ deficient mice post ischemic injury. Next, we looked at fibrosis by cytoma staining as well as the collagen immunostaining and quantified, and we see there is a significant reduction in terms of fibrosis. And this correlates with downregulation of majority of the myoblast formation genes. They are downregulated, as well as the collagen biosynthesis and remodeling genes. They are significantly downregulated. In addition to that, we also observed that improved post-MI angiogenesis in the YAP-TAZ deficient heart, and this was associated with increased expression of VEGF and VCAM at both time point day 7 and day 28 post-MI. So just to summarize this, what we have learned in this study is that YAP-TAZ, they regulate M1 gene expression and help, so that they are in pro-inflammatory in nature, they help to boost the immune response. But when in the M2 phase, what they do is they interact with SDAC3 and M4 repressor complex and repress arginase-1 expression or in general M2 gene expression. And in this state, what you have, you end up with massive cardiac fibrosis and a compromised cardiac function. But if you inhibit YAP-TAZ or delete YAP-TAZ, this balance is cystic. So you have a less inflammation and you have more pro-fibrotic or anti-inflammatory behavior of these macrophages. And what that helps is that they reduce the cardiac fibrosis and you see improved angiogenesis and improved cardiac function. So with this, I would like to just acknowledge my lab. Majority of this work was done by a senior research fellow, now he's a research scientist, Masoom, and CB here. And I would like to just thank the funding agency for supporting this work. And last but not least, thanks to all of you for being here and for hosting us. Happy to get
The flow function. No questions from the floor?
Thanks, Ravindra, for a nice talk. Are there therapeutic modulators of the YAP-TAZ pathway that have been tried in ischemic treatment?
Yes. So Jim Martin, who will be visiting in a week at Duke-NUS, so he has founded this company, YAP Therapeutics. So they are trying to target this pathway to improve cardiac regeneration in pig models. They have shown that if you overexpress YAP using the AAVs in pig models, it does help to improve the regenerative process. Not that I'm aware of, but a lot of companies are trying to either find a kinase inhibitor or try to find a YAP inhibitor or find even TEAT inhibitor. So I think there is a clinical trial going on with the TEAT inhibitor. So this pathway is not only relevant in this setup, but it's also relevant in cancer. So it has a problem.
Thank you very much. Very interesting. Do you know if there is an influence of the complement system on this? Is there an influence of the complement system on the expression of YAP paths?
Yes.
Because the complement system is also known to reduce or in one or two depending.
Yes, we have some preliminary data suggesting that it does affect. It does affect the complement system.
Because the other way around.
No, so YAP has regulate a component of the complement system. That's we know, but it's like we haven't done any. We just got the data, so we know there is something there, but we need to explore it deeper and understand how it's affected.
Because if I'm not wrong, maybe Klaus, you can help me, or Charlie, you can help me. So I think C3 is important for M1 polarization. Complement factor C3.
I know C3, and so we have some evidence that there is a regulation of C3, there is a regulation of F10 by YAP.
Okay.
But we don't know how that regulation is going to have whether positive or negative impact in this setting. That's we still need to do that. Like no, there is. But definitely there is something.
Okay, wonderful talk. But this YAP signal is quite important in the heart regeneration aspect. I didn't do anything, but I saw a lot of literature reports. So in your case, you focus on the macrophage YAP signaling. So what's the contribution of the cardiomyocyte YAP signaling in this case?
Yes, so there's a lot more work that we done on cardiomyocytes because that's where it was identified. So if you overexpress, so if you delete the kinase, it means you are activating YAP that can make your heart bigger during the embryogenesis. So that was considered as a positive result. But if you do the same thing in an adult heart, then it can cause arrhythmia. So it's still, I think Jim Martin has done William tools. There's many labs like looking into that one. So that's why we decided not to go in that direction. But my interest was looking into the role of epicardium because epicardium contributes to fibrosis. Epicardium contributes to the vascular endothelial cells, which can revascularize the tissue. So I feel that is a better target for minimizing the damage or helping with the repair process than trying to make a post-mitotic cardiomyocytes to proliferate, to go back into the cell system and then proliferate and make more cardiomyocytes.
I totally agree. I think the repair is probably better than the regeneration, right?
Yes, I honestly believe that there is no regeneration in adult heart. I mean, making one cardiomyocyte into two doesn't help to fix the heart. But as a proof of principle, yes, it does. You can, by overexpressing YAP, you can make one cardiomyocyte.
Thank you very much, Dr. Singh.
Thank you, Dr. Singh, for this nice presentation. Our next speaker will be covering the following topic: toll-like receptors in cardiac injuries. Professor Jong Wei Wang. Dr. Jong Wei Wang received his PhD in medicine from the Leiden University Medical Center. He moved to the National University of Singapore. He was promoted to assistant professor in 2019 at NUS Yong Lu Yin School of Medicine, Department of Surgery, with joint appointments at the Department of Physiology and the Cardiovascular Research Institute. Dr. Wang is also a principal investigator in the Nanomedicine Translational Research Program. His current research focuses on cardiovascular immunology and preclinical development of nanomedicine with natural and/or synthetic nanoparticular systems for the treatment of inflammatory and metabolic diseases, including cardiovascular disease. Please bring your hands together for Professor Wang.
Thank you so much for such a nice introduction. I'm sorry to provide such a long CV. Good afternoon, everyone. Thanks so much for staying till now. I think I'm the last speaker. Hopefully, it's not the worst one. So that's my talk. So before I touch my research topic, for today's presentation, I first would like to give an overview of my research lab, since it's my first volunteer meeting, especially, and to have this meeting, and it's a wonderful place in Mauritius. And to my left, have two main research lines, the cardiac immunology part, so I will talk about today. And on top of that, we have recently evolved into nanomedicine. So we use the different nanoparticles, including the lipid nanoparticles, for RNA delivery. And this is for imaging and drug delivery in a different perspective of disease, including cardiovascular disease, fatty liver disease, and our recent efforts also have been put into the gut, liver, gut, heart, gut, brain axis. So that's quite a bit of a broad topic. But for today's talk, mainly look at the cardiac function, and especially in the context of the immune activity in the myocardial function. And for this topic, I talk a bit more on the Toll-like receptor, which are the sensors for the innate immune system. And the Toll-like receptor, so far, have been discovered 10 different members in mice. And 10 different members in human and 13 members in mice. But mostly known with the known functions, those are some receptors located on the cell membrane. It's like Toll-like receptor 2 and 4, most of the famous one, and also the discovered earliest. And there are also a group of Toll-like receptors. Instead of they're located on the cell membrane, they're located in the endosomes or lysosomes, internal membrane, like shown here, the Toll-like receptor 7, 3, and 9. And for today's talk, I will focus more on Toll-like receptor 7, which is, involved in a systemic lupus. It is a type of autoimmune disease. And there's more relevantly to this Toll-like receptor 7 could detect the cell nucleic acids, in addition to the virus infection. It could detect the cell nucleic acids and enhance the immune response. And in this case, there's also some clinical studies notice that there are higher chance of the patient to have myocardial infarction in this systemic lupus patients. So this and this concept is also evidenced by the Toll-like receptor 7 promotion of the diet-induced atherosclerosis in animal models. So our question is, does the Toll-like receptor 7 also contribute to cardiac injury and also the heart remodeling after the myocardial function? And to address this question, so we use the mouse model of the myocardial function. And the first we check is to see the clinical relevance. We look at the patient samples from the ischemic cardiomyopathy patients, and we can see that the Toll-like receptor 7 expression is much higher compared to the healthy hearts. And in the animal models, after the myocardial infarction, you could also appreciate the very rapid increase of the Toll-like receptor 7 expression in the infarct region of the heart. And more strikingly, so when we perform the permanent ligation of the LAD, and we appreciate that in the wild type, so it's in the red line, it's around 35% of the animals will die of heart rupture within the first week. And in the contrast, we only have 2 out of 31 mice that died in the knockout mice. And the other 2 died delayed, after, 3 weeks, they died, but not cardiac rupture, but rather for heart failure. And so this means, the Toll-like receptor 7 could exacerbate the heart cardiac rupture. And to understand the mechanism, we have to know that, the male fibroblasts in the heart, they are activated in the context of heart injury, and therefore they could contribute to, the fibrosis and also heart repair. And in this, we checked the activation of the fibroblasts. So by expression, determining the expression of RSNA, and also the both mRNA level and also protein level. I'm sure you can appreciate that. And after that, 20 days after myocardial infarction, we also checked, the fibrosis or the scar formation at the infarction region here. Compared to the wild type, you see the scar much dense. If you look at the polarized filter, so the fibers formed in the scar area in the knockout mice is much more mature compared to the wild type mice. So this partly explains why the knockout mice have less frequency of the cardiac rupture. But this increased fibrosis in the scar region does not affect the heart function. In fact, we see improvement of the heart function in the knockout mice. From here, evidence that left ventricle ejection fraction, and you can also see much less remodeling. So the dilation of the heart chamber is much reduced in the knockout mice. And of course, since the toll-like receptor 7 is the sensor for the immune system, so we look at its effects on the infiltration of the innate immune cells, for instance, the macrophages and also T cells as well. And if compared to the wild-type mice, you could see the much less immune cells infiltrated in the heart, right? And it's also evidenced by the cytokine expression in the heart. So when we got the data, we asked the question, so where is the TIL7 receptor, TIL7 expressed, and which type of cells contribute to this cardiac phenotype? And when we checked the literature, there was one study a few years ago, and they should indicate that both the bone marrow derived macrophages and the cardiomyocytes may express the toll-like receptor 7. But the question is, which type of cells contribute to the cardiac rupture and the cardiac dysfunction? To address that question, so we did the bone marrow transplantation experiments. And so basically, you do, cross transplantation, either wild-type mice receive the knockout bone marrow or the other way around. And our data indicates that it's really the bone marrow is the bone marrow derived immune cells contribute to this to the phenotype what we appreciated early on. So that's question us, does the does other cardiac cells express the toll-like receptor 7, or it's only expressed in the immune cells? So we isolate different cells, different type of cardiac cells, including the cardiomyocytes, of course, fibroblasts, the macrophages, and also endothelial cells as in the show here. But our staining data clearly show that the toll-like receptor 7 actually only expressed in the macrophages instead of cardiomyocytes and endothelial cells. And we have more data to support that. For the time being, I will skip. And so next to this topic, so that's a previous part I already published in a few years back. And next to that, so we asked the question is, does toll-like receptor 7 also contribute to the ischemia reperfusion injury? Yesterday, Prof. Yellen and Prof. Derek Olsen talked about it. Right? So it's more clinically relevant. And for that, this one, of course, it's very famous figure, everybody is saying that. I will not talk too much about that. So our question is, does toll-like receptor 7 contribute to the ischemia reperfusion injury? And for that, we did this animal mouse model, 30 minutes ischemia and followed by reperfusion. And from here, you can appreciate that the expression of toll-like receptor 7 in injured heart increased. And also more striking, and we did really a lot of mice because of two postdoc and one PhD students involved. Everyone wants to do their own experiment. And so from here, you can appreciate that, in the toll-like receptor 7 knockout mice, the effect size is much smaller compared to the wild-type mice. And for that, to understand the mechanism, we noticed that in the knockout mice, in the heart, there are much fewer apoptotic cells as shown in the green color. I hope you could appreciate that, otherwise you have to trust me. So this first, we also showed that of course, toll-like receptor 7 knockout mice have much less inflammation in the hearts. But to our surprise, we did not see any difference in terms of the neutrophil infiltration. And for that, we checked that, there's actually the netosis. So I think Sean mentioned that yesterday. So the netosis is involved in the cardiovascular disease. And so we like to test the idea whether this is also involved in our case. And to our surprise, even though the toll-like receptor 7 is not expressed in neutrophils, but it somehow affects this netosis, the neutrophil, the net formation. If you could appreciate this red color stands in histone 3, right? In the knockout heart, there much less netosis occurs. And so we like to understand why that. So we came up with another hypothesis. Is even though the TILA7 is not involved in the netosis, but it may directly affected by atherosclerosis instead, right? So those atherosclerosis, I think one of the speakers mentioned that earlier. But just so that the immune cells, they could take out other apoptotic cells. In a way, they could convert the pro-inflammatory macrophages even into the reparative macrophages. And in this case, to test this hypothesis, we measured some, atherosclerosis related genes expression in the infected hearts. And as you can appreciate here, this is CD31, which is, promoting the atherosclerosis is highly expressed in the knockout heart. And on the opposite, the anti-atherosclerosis protein, the GSD1, is much reduced in the knockout heart. And going to the molecular level, so what's the mechanism? We do not know yet, but we have some speculation. And one speculation is, the single-strand RNAs released from the dying cardiomyocytes. They could come along with this MDB1 protein and to get into those immune cells and activate those toll-like receptor 7 in endosomes or lysosomes. And there is a recent Nature paper from Hoffman, just published a few months ago. And they noticed that the mitochondrial RNA could also, activate the toll-like receptor 7 in certain sense, especially in the systemic lupus, so those autoimmune disease. So that's our speculation, and this is still ongoing projects. So we are still trying to figure out what's exactly the molecular mechanisms. And to conclude, so what we have discussed both in the permanent occlusion model and as well as the ischemic reperfusion injury model. So this toll-like receptor 7 is involved in the activation of the innate immune system, and this innate immune system, causes some apoptosis, of course, and there's also some apoptosis because of lack of oxygen or blood. So there's a cardiomyocyte, the undergo apoptosis, and we think this apoptosis, may induce the netosis of the neutrophils, and this netosis could try to clear this apoptosis. But the meanwhile, so this netosis may also cause further or more cell apoptosis of the hepatocytes, and this is a vicious circle. And the good thing is with the toll-like receptor 7 inhibition, it could enhance the atherosclerosis. In a way, they could clear this apoptosis is very more efficient. And in the meanwhile, they could, convert these pro-inflammatory macrophages into replicative macrophages, or you call it M2 macrophages. And in the way, they could repair the injured parts. And with that, I would like to acknowledge all my groups, some past members, some current members and newcomers, and of course, a lot of collaborators from Europe and Singapore, of course, and the founding bodies. And thanks so much. I would like to take questions.
Okay, Dr. Price, huh?
Joe, thank you very much for this interesting talk. Coming back to the penultimate data slide, where you kind of speculated about the possible ligands for TLR7 action. Do these hypothetical ligands indeed represent the sort of quantity of ligand concentration, etc., that drives the TLR7 action in this dramatic way? Because you showed the expression of TLR7, wild type versus the knockout, and I mean there's quite a big difference. So do these kind of little things really are representing the power of putative ligands that are active?
That's a very good question. And actually, we do not have a clear answer yet. But we already did some very preliminary studies. We used the toll-like receptor 7 antagonist. This short sequence of DNA. And this, with that inhibitor, we did see some improvements of the heart function. But the thing is, this free DNA sequences, they go everywhere, and also the half-life is quite short. So currently, my team are trying to make nanoparticles, and decorate those inhibitors on the outside of the nanoparticles. Then you feed the macrophages, and hopefully they bring this to the heart as well. And in the case, in that sense, so we're trying to, to prove that functionally whether the TLR7 is really contributing to this cardiac injury.
I think there might also be a kind of alternative explanation or this idea that TLR7 is just the start of a chain reaction. So an initiator that induces, let's say, cytokine release like alpha, etc., which then amplify the injury that is produced.
Yeah, I absolutely agree with that. Especially when we saw the netosis, I'm sure it's not a direct effect because there is no TLR7 expressed on neutrophils at all. Right? So that's, but how that happens, we are still trying to explore. And of course, I think, yes, the toll-like receptor 7 is very, upstream, very upstream. And the downstream, we saw a lot of cytokine, chemokine, change. But that's more like the end products of the effectors. Yes.
Thank you.
Yeah, thank you.
Oh, very interesting talk. Very nice. Thank you very much.
Thank you.
So you said the toll-like receptor 7 is expressed on macrophages.
Yes.
On all or more on M1 macrophages or also M2 or?
That's a very good one. So basically, so far we checked the macrophages, from bone marrow differentiated macrophages at the different stages, from we call it M0, M2, or M1. You could use a different cocktail to induce them into different types. And we also isolated the cardiac macrophages. We don't know exactly which stages they are. I guess it's a mix. And we also checked the macrophages from the peritoneum, and all of them express the toll-like receptor 7. And But to our surprise, is somehow when we for the knockouts for the macrophage, the lack of toll-like receptor 7, they are more M2 phenotype. This is something we are still trying to explore, and they have enhanced phagocytosis activity.
The second short question. So for NETs, you said you stay for histone 3. And which other marker did you use for neutrophils?
We use histone is 3, so they just to as indicator for the mitosis. But I think you or Sean probably have more things on that.
The idea is that also macrophages can produce nets, so they're not called neutrophil extracellular traps, but macrophage or monocyte extracellular traps. So my question is, are these really nets, or might those also be mets derived from macrophages?
That's a very, very good question. Yeah, we should check that. And of course, in the heart, we don't know, because in the tissue, we use the AG3 staining. We also use the DNA staining, but we cannot detect whether it's from macrophage or neutrophil. And in vitro, we also induce the netosis, but it's purely on neutrophils, of course. Yeah, but with macrophages, it's really something new. I should do a study on that. Thanks so much. Thanks so much. Very good point. Thanks.
Great talk. I just wanted to ask you about the macrophages. You mentioned the TLR7 knockout macrophages are more M2, right? So what is causing? So they are more fibrotic, like profibrotic macrophages. Yeah. What is causing the rupture in this knockout?
The rupture of the heart, you mean?
Yeah.
The rupture of the heart is mostly MMPs, I would say. But so far we do not understand very well. Yeah, we saw the MMP2 and 9 the activity highly expressed, so the highly enhanced in the one hearts.
Do you think like maybe loss of inflammation has anything to do with that?
No.
You don't have neutrophils, you don't have macrophages going there, you don't have T cells.
Oh no, I didn't show the data. Actually, there are. So but in the knockout parts, actually you have much fewer macrophage and T cells. So the neutrophils we don't see difference. That's why for the follow-up study, we are starting to look at neutrophils more, because macrophages in T cells we already knew, in the previous publication. Yeah, and back to your topic, your question regarding the rupture. One thing is MMPs, of course, but we are also thinking it's probably in the TLR7 deficient macrophages. They are more reparative and more pro-fibrotic. Right? So that's maybe one of the reasons as well. And also we see more, activation of the fibroblasts into the male fibroblasts. They are the ones who produce the fibers, right? But from the macrophage to the fibroblast, how does it work? We don't know, because fibroblast does not express the TLR7 either. There must be probably back to your topic. Probably there's some interaction between the macrophages and the fibroblasts. We should talk later. Yeah. Thanks.
More questions from the audience? So, okay. Thank you very much, Dr. Wang.
So thanks again, Dr. Wang, for this wonderful presentation. Our final speaker for this session will be enlightening us on the progress and advances in cardiology in Mauritius, Dr. Mohammed Nizam Duma. He is a consultant cardiologist working full-time in the private practice at Clinique Dornier in Floreal and Welkin Hospital, Mocha, Mauritius, He is a former member of the Medical Council of Mauritius and is the former president of the Cardiovascular Society of Mauritius. He is also the ex-consultant cardiologist and head of cardiac department at Victoria Hospital. Please give a round of applause for Dr. Dugas.
Good afternoon to everybody, and I would like to thank the organizing committee for having invited me to talk today. But straight away I will tell you that my lecture will be it will be less technical, and because what I thought is that many of you are from abroad and you don't know how the cardiology services are. And I thought it would be a good thing, because we are talking about cardiology, to give you an overview of our services in Mauritius. First of all, I would say that, before the 1980s, cardiology was inexistent in Mauritius. Let's say that people who were suffering from cardiac disease were being dealt with by the physician, and they did the work very well. But the thing is that they had only at that time, if they are fortunate, they have an ECG, a chest X-ray, but mostly was very good clinician, and they made most of the diagnosis. And at that time, most of the diseases was rheumatic valve. We were really facing with problems of valvular disease and their complication and the high rate of mortality as a result of this. People who were fortunate, thank you. People who were fortunate at that time, and if they can pay for it, they were gifted abroad, and they had either surgery or further investigation abroad. And the first cardiac unit, in fact, started in the year 1982, and it was at the cardiac unit at Victoria Hospital. I would say at that time as well, it's the same thing. We had only a full ECG single channel. We worked once or twice, once every fortnight, and and when we started, we had only an M mode echocardiography. Then, because of the high incidence and at the time of valvular disease and its consequences, heart failure, endocarditis, etc., then there has been a protocol of agreement with the Ministry of Health and with the foreign cardiac teams, and they came to Mauritius to operate on our patients who were sick, severely sick. And imagine at that time, there were, as I told you, practically no ECG, there was no echocardiography. And these people, they had to come as a foreign team with all the facilities to operate on the patients. The first to come was a Professor Rafa, who was from Saudi Arabia. And he did, the first time he come, he did about 30 cases of open heart surgery and valvular disease, and then followed by Professor Seren from France, Saxena, and then from UK, and Russian team as well did come. Before they come, we had got not cardiac surgeon, but we had a cardiac, a surgeon, but with competence in cardiothoracic surgery, and they did mainly closed mitral valvulotomy, and also PD occlusion. Then afterwards, as I will show you, that this was the era where it was mainly valvular disease. And this is what it looks like today, the first cardiac unit at Victoria Hospital. We are a population of about 1.2 million residents, and 80% of the population are 80 or more. 80% is more than 18 years, and our life expectancy is about 70 years in males and about 77 years in females. Cardiovascular diseases is a real burden, but it has shifted from valvular disease now to coronary artery disease, which is as it is in many of the developing countries, a clear burden and responsible for about 35% of all cause death. In this slide, you see that the death, we have a high incidence of diabetics, and you can imagine that ischemic heart disease as well will follow, stroke, and this is the graph. I can show you this. This is the give you an idea of the incidence. Give you an idea, we've got about 41% who died of circulatory disease, and the rest is as it is. And progressively, from this, we have been having a steady increase in cardiac diseases. This as well show you that the incidence of death due to myocardial infarction is about 30%, 13% total, including males and females, and the rest is not. How our health system works. Our system works on the system of the British health system, the NHS, and all medical services in the public sector are free, whether it concerns admissions, imaging, surgical intervention. We start from an angiography, we go to the PTCA, to an open heart surgery, dialysis. But in the private sector, it is insurance paid or self-paid, and it costs a lot of money for those people who cannot afford. A 24-hour service. Our healthcare delivery, we've got about 3,700 beds in the public sector and 1,000 in the private. And we've got 5 major hospitals, 2 districts, 6 specialized public hospitals, and 1 cardiac surgery center. One cardiac surgery center, which is based in Pamplemousse, and 11 private clinics, private health care, where we give the primary care, and then eventually we also promote control of the diseases. The super specialty that we have a cancer hospital and a cardiac center, as I told you. This is Mauritius. This is Mauritius. So this is from Fortress, one of the major hospital. The second one is somewhere in Catrobon, the Victoria Hospital. This one is the hospital in the south, which is the GNH Hospital, and this one in the Clark Hospital. So this is the cardiac unit I showed you earlier. Now in the private institution, we've got a few clinics, 11 clinics, starting with the Clinique d'Arnay, which is the oldest one and highly sophisticated, because we've got all the facilities here. City Clinic, where they do angiography and coronary stenting. Clinique-Mauritius, Clinique and the rest. And we've got also Welkin Hospital, which is Apollo Bramwell, which is equipped with all facilities, whether it is angiography, angioplasty, cardiac surgery, and a newly recently opened in 2 months back, Artemis Hospital. Our doctors, how many doctors we are? We are about, in the public sector, we are about 1,661. Out of them, 1,200 are GPs, let's say medical and health officers, and then we've got 450 specialists in the different fields. And the private, the number of doctors, we've got 3,800, out of which is 1,100 are specialists. Let's say that when I say 3,800, those are brought by the clinic, private clinics, and then all those doctors that work in the private surgery. Now, the training centers in Mauritius, where are our doctors trained? Until recently, practically most of the majority are trained outside Mauritius, and in England, in France, in Russia, in Germany, in Australia, and even many are trained as well in China. But the two local training centers we have is the SSR Medical, where we are actually, and the University of Mauritius. How many cardiac centers? In all of the regional hospitals, we've got the cardiac center, we've got the cardiac unit, and you can see here, this is G2 Hospital, Nehru, Brunechong, Victoria, and SSR, and then the cardiac center where cardiac surgery is being done regularly. The first coronary angiography was done at the cardiac center in the year 1992, and coronary angioplasty shortly after. Actually, interventional procedures like angiography, peripheral, and coronary are done in 2 of the 5 regional hospitals where they are equipped with coronary angiography facilities. And one is shortly to be opened at Nehru Hospital. Primary angioplasty was currently done in the public hospital during working hours 8 to 4 p.m. because of lack of manpower at that time, because there were not many cardiologists who can stand as first operator, and we work only during 8 and 9, 8 and 4, but anything like a failed thrombolysis, we had to take them, because in one of the centers, there was only one interventional who can practice it alone. And in the private sector, anyway, primary angioplasty was already done on a 24 basis. Already been a practice, because in the private, the work is different. So, now you can see on this slide, that cardiology is a very important part of our outpatient department. 129 attendance in a year when we compared with the other specialty, which is surgery, for example, is 90,000, and we are the highest rate of attendance. What do we have in the cardiac unit? So in the cardiac unit, we have, of course, the basic ECG, the 12 channel. We have echocardiography, which is high-end echocardiography, which runs esophageal echocardiography, and the stress test machine, coronary care unit with 12, 20 beds, the head of unit, the cardiologist, 5 to 8, and the number of RMOs, which is about 5 to 10. The activities that we do in the cardiac unit at G2 Hospital, you've got both invasive and non-invasive, that is ECG, echo, and stress testing, and implantation of permanent pacemaker. At Nehru, you've got non-invasive until recently, but shortly an angiography machine is going to be installed. Brunechong Hospital, they do only invasive. Just to mention that Brunechong was one of our colleagues, and during the COVID, he passed away, and the hospital was called before Flak Hospital and took the name of Brunechong. Victoria Hospital, they do about 2,000 invasive angiography, angioplasty, pacemaker, and we started to do ICD, we started to do CRT, CTOs, plenty of CTOs, IVUS, protablator, and SSR Hospital where it is done invasive. And all these procedures we were doing at Victoria Hospital. And in case only difficult cases which needed surgical backup was being sent to the cardiac center. Then you've got in the private clinics, the clinic Bodone at Floreal, and we have the cardiac. They do about 1,000 angiography with 700 plastic, and cardiac surgery is 200, working in the same where they do angiography and angioplasty. A cardiac center, just a Whiteland Cardiac Center, where they do interventional cardiology, and they do pediatric cardiac intervention with also surgery and vascular surgery. This is where this is found in the North Hospital near to Pamplemousse. The type of operation they do, ischemic, as you see, is the majority of cases are ischemic, as you would guess, and then these are valvular disease. We still have a few valvular disease. Most of them are imported cases from Comoro Island, from Madagascar. They do come here to get operated, and then of course the congenital disease. This is an idea of how many cases have been done, open heart surgery. In the years, it increasingly every year. From 2018 up to 2018, there was 818, and today there is about 1,000, more than 1,100 a year. The cath lab procedures as well has gone up from, there has been a slow increase here because of the COVID, the cath lab bottom. And what next now? We will be shortly having the catheter valvular TAVL, which is the implantation of valvular aortic, and then it's coming shortly. I think this is to give you an overview of what we are doing here. And we have made a lot of progression from where we were only 40 years back and where we are actually. Thank you.
Thank you very much. And would you take some questions if there are some questions for you in the audience? Well, if there are no questions, I'd like to congratulate you on this incredible progress in your country. And on the program is now, well, you take care.
Thank you, Dr. Duma, for your insight of Mauritius cardiac facilities. We will now proceed with certificate for this session. I'd like to invite Professor Fogel, please, on the stage. I would like to invite Professor Ramachandra on stage, please. Can we please invite Professor Singh on stage, please? Thank you, Professor Fogel. Can I please call Dr. Batu on stage, please? Can I please call Professor John Wang Wan, please? Can I please call Dr. Duma on stage, please? Thank you. Now we'd like to invite Dr. A.P. Singh to proceed to deliver the certificate for our chair, please. Can And I invite Professor Fogel on stage, please. Can you please invite Dr. Bakru on stage, please? Thank you for this session. We will now proceed to a coffee break, but with laws till 16:45. During this time, the two moderators, Esha Year 7 and Derek Law, are please informed to join the tea hall where their coffee will be served. Others may follow their coffee break. Thank you for your second.